Thanks, everybody. Thanks for joining. Dan, thanks for everybody else for joining as well. I just want to introduce my friend and colleague, Dan Werb, who's an associate professor here at UC San Diego in the Division of Infectious Diseases and Global Public Health. And he's an amazing researcher, especially related to substance use and related epidemics. And he's also an amazing journalist and author, and has written 2 books, including one about COVID and one about HIV and the border region and substance use. And today he's going to talk about substance use related to epidemics in North America, a tale of 2 crises and 2 futures. So I'm going to turn it over to you, boss.
Thanks so much, Davey. So I am just going to share my screen here. Hoping, oh goodness, where did this go? Hoping everyone can see that. If you can't, just pipe up. Thanks for the opportunity. Okay, awesome. Yeah, thanks so much for the opportunity. And, thinking about what I was going to prepare today for Prepare, I know, of course, we're focused primarily on infectious disease, epidemics and pandemics, but, at the same time, I think bringing in the sort of social epidemiology aspect and understanding some of how that influences health epidemics in particular can be really helpful. So this is a bit of a history lesson mixed with some research that I've been undertaking. So yeah, I'll just take you through it. And just as a point here, I just want to declare a potential conflict of interest here. I'm developing a mobile drug checking technology, and there's some data that I present here from a drug checking service that I help lead in Toronto as well. So just wanted to note that before I continue. And just a land acknowledgement around this center. As some of you know, I'm cross-appointed at UC San Diego and at the University of Toronto. So this is a land acknowledgement related to the work that I'm presenting today, which is based somewhat in Toronto. So very briefly, limits of drug policy, and then going through 2 crises, and then basically looking at what might help us move forward. So, I think it's really important to understand when we talk about substance use, when we talk about substance use related epidemics, to begin with the limits of drug policy, right? Because we know that substance use is so, and the kinds of outcomes that people experience related to their substance use is so predicated on the types of drug policies that are in place to that influence that, and influence availability, access, but of course also criminalization and what happens, the social consequences, and ultimately the health consequences of substance use. So it's important to note that in the United States, drugs were more widely available in the years after government spending on interdiction increased. And so, you look here through the through the mid-noughts, through the mid-aughts, or maybe it's the other way around. I can never get that right. Basically, mid-2000s to mid-2010s, you can see that government spending on drug control actually increased quite a bit. And then at the same time, you see that when that government spending increased, you see, of course, a concomitant increase in seizures of cocaine and cannabis in the United States. But then what happened, right? We actually see during this time an increase in the potency of cannabis. In fact, a pretty remarkable increase right around the time that seizures increased, and a reduction in the price per gram. So when you've got increasing potency or purity and decreasing price, those are 2 signals that availability is increasing. So obviously, suggesting that interdiction isn't working here. At the same time, you saw the levels of substance use actually increase, particular to cannabis use in the United States during this period as well, beginning around 2008, 2009, when this government funding increased as well. This was not unique to cannabis. We saw the price and purity, the price per gram essentially of heroin drop pretty precipitously. Price, while non-linear, increased Purity basically increased, again, suggesting greater availability at a time when interdiction was being introduced. But this is not unique to the United States. The United States is overwhelmingly reliant on interdiction, but we see lots of seizures elsewhere. And we also saw in Europe a similar focus on seizures, and yet a reduction in the price of opiates and cocaine during the same period. Now, aside from interdiction, there's of course efforts at trying to employ social marketing to reduce the use of drugs and demotivate particularly young people. But unfortunately, in an evaluation of this National Youth Anti-Drug Media Campaign, which cost US taxpayers over $1 billion, it was found that when the Government Accountability Office undertook an evaluation of this campaign, this $1.2 billion campaign, they found that campaign exposure is associated either favorably or unfavorably, was not associated either favorably or unfavorably with any of the initial cognitive outcomes that they were trying to generate among youth. So basically trying to change intentions, attitudes, beliefs, social norms, and self-efficacy around substance use. However, there was one impact of this $1.2 billion campaign, which was to increase the perception among youth that other kids were using cannabis. So, and we all know what happens when young people think that everybody else is doing something. It can inadvertently increase the likelihood that they may do it as well. So in conclusion, what we found here was that the social marketing, what the Government Accountability Office found was that the social marketing campaign, $1.2 billion actually potentially increased the risk that people initiated cannabis. But again, when we're thinking about the limits of drug policy, this is not unique to the United States. And this is a really interesting study that was undertaken by Louisa Degenhardt for the World Health Organization. And her and her team essentially looked at the age at first use of different drugs across a diverse set of countries. And you can see, these are countries including New Zealand, Colombia, Belgium, Mexico, the United States, Lebanon, Israel. And what is remarkable, despite the diverse settings and the diverse societies and cultures, and of course, diverse drug policies that are applied, is that the age of onset of the use of cannabis is remarkably similar in all of these countries, suggesting that drug policies in and of themselves are not the main reason or the main influencer on whether people do or do not use drugs. So as they concluded, drug use is not distributed evenly and is not simply related to drug policy, since countries with stringent user-level illegal drug policies did not have lower levels of use than countries with liberal ones. And I think that's, again, really interesting, but of course, important to note when we're crafting responses to substance use-related epidemics, what are the limits, right? What are the limits of these policy tools? So what are the lessons that we can learn from these historical events? So one is that people use drugs for factors beyond the control of drug policies. Also that drug markets are regulated. We often think of sort of drug markets as totally unregulated, but the question is just really who is doing the regulation? Is it government in the case of alcohol, tobacco, in Canada, cannabis as well, and in certain states in the US as well, cannabis is regulated, of course. But for illegal drugs, those markets are regulated as well. And it's who regulates those that and how they are regulated that shapes how and whether people use drugs. Less well-regulated markets, as we've seen across North America, can change rapidly and can place people who use drugs at grave risk. So again, I think this is very policy heavy at the beginning, but we'll get into some of the data soon, that when we think about what is possible with drug policies, we should think about moving, and not simply trying to end substance use, but moving people from more harmful types of drug use to less harmful types, more harmful modes of consumption to less harmful modes, and more harmful drug use behaviors to less harmful drug use behaviors to reduce negative health and social consequences and epidemics. And I'll just say, like, we know that you can take policy approaches that can reduce some substance use, but it takes a long time. So this is evidence from Canada that took a really hard but considered policy stance on smoking and tobacco, commercial, like just basically the commercialization of the tobacco industry. And, it took a long time, but saw a pretty linear drop over decades in the prevalence of tobacco smoking. So another lesson that unfortunately we've learned across North America when we think about the overdose epidemic is just because a market has been predictable for a long time is not evidence that it will continue to be. And before we get into that second major epidemic that we're dealing with, I also wanted to just talk about another epidemic that was driven by substance use that I think is a really interesting case study in what happens when drug markets shift and the kinds of responses that are required to end the crises that emerge. So talking about the HIV epidemic in Vancouver, Canada, my hometown, when that emerged in the 1990s. So, at the time, it was a pretty remarkable situation that within, you had this area, the downtown east side, 16 square block area that was kind of the major neighborhood where public use of, public injection certainly, but just public drug use had been occurring for decades, right? Basically since the 1950s. But suddenly in the 1990s, you saw this massive, rapid acceleration of HIV transmission among people who use drugs. And what was found was, on the one hand, and this is not going to be news to anybody, that people who did not have stable housing, who injected drugs, were much more likely to acquire HIV than those who had stable housing. There's a really interesting other facet to this, which is that it was found that people who injected cocaine actually also had a much higher risk of HIV acquisition compared to those that injected heroin or injected cocaine only infrequently. And this issue of cocaine is really interesting because it was actually motivated by changes and US policy in Latin America that sought to dismantle the duopoly of the Colombian cocaine cartels that had existed for a very, very long time. And this dismantling of the duopoly radically shifted the international cocaine trafficking patterns that had been in place for quite some time. Now, the end result of that was that suddenly in the early 1990s, or in the early to mid 1990s, there was this shift where a city that had been predominantly supplied with heroin suddenly had this massive increase in cheap and available cocaine. And what happened was because availability is the greatest driver of substance use in terms of what people will decide to use, is that people who had been historically or been just injecting opioids in the form of heroin suddenly shifted to cocaine. But the half-life of opioids and of heroin, basically people who are very, very dependent may inject 2-3 times a day. The half-life of cocaine is much shorter. So you had people who had suddenly started to inject up to 20 times per day when they were injecting cocaine. And of course, that frequency of injecting just precipitated greater risk of transmission because there weren't sufficient sterile syringes. There was, of course, every time that you inject, if you're sharing syringes or using contaminated syringes, your risk of HIV acquisition or transmission just rapidly increased. So this epidemic that happened, which is this HIV epidemic, was really driven by market forces, very, very similarly to the overdose epidemic that we're experiencing now. And I'll just say that, for those that don't know, first of all, Steph Strathy, our beloved Steph Strathy, colleague here, was one of the researchers that first sounded the alarm and identified that HIV prevalence among this population of people who inject drugs in Vancouver's downtown east side neighborhood had reached close to 30%. So 30% HIV almost. So that was a really stunning revolution, and it was the highest prevalence epidemic outside of sub-Saharan Africa at that time. And so, I'm not going to belabor this point too much, but the point is that basically, first of all, that syringe access was a key driver of HIV infection. And the issue here was that at the time, there was not a sufficient, there was a centralized needle exchange program in the city of Vancouver. But as the cocaine, the shift in the cocaine trafficking route changed availability, suddenly that centralized service was not sufficient to meet the needs of people who had suddenly started to inject much more frequently. Now, what happened as a result was a simple fix, that this centralized needle exchange program was changed to a decentralized needle distribution service. So rather than a one-for-one exchange, it was just switched to a distribution service. People could have as many syringes as they required, and the acquisition, or like the retrieval of used syringes, was separated out from this from needle distribution. So they became two totally separate services, no longer an exchange. And needle distribution was essentially decentralized into every single healthcare clinic that existed or was in place in Vancouver. So rather than going to a central location, people could basically pick up syringes anywhere they went. And what that meant was that, as you can see here, these two graphs, that the reporting of syringe borrowing and syringe lending basically dropped by over half immediately, or not immediately, but very, very rapidly after this change was put in place. And I'll get back to that and a few other innovations that happened there, but that decentralization of the syringe service was really the biggest one. Now, the second crisis that we're all living through, I don't want to belabor the point here, but we know that initially driven through basically a combination of diverted prescription opioids, legally prescribed opioids, and heroin use. And of course, that's shifted. But I think what's interesting is that this has not been a linear trend, right? The overdose epidemic, it's not like the precursors of this epidemic or the fundamentals have been static. There have been some major changes, and actually we're talking about a multi-wave epidemic that each wave has been sort of driven by a different fundamental factor. So the early roots of the crisis, I think, as many of us know, is related to the fraudulent expansion of OxyContin prescribing, driven by Purdue, which of course now all of this has been proven in court, but used fraudulent methods to increase the prescribing of this drug, and that led to these are data from rural Appalachia that led to a period in which individuals had begun to, at least in some parts of the country, begin to initiate injection drug use. The roots of the second wave, and here these are data from Canada, but they're similar, I think, to what happened in the United States, is that after this expansion of OxyContin prescribing, there was a focus on government and other stakeholders to reduce access, right? So to do whatever was required to suddenly end access to OxyContin. In the case of Canada, OxyNeo was this apparently tamper-resistant, slow-acting formulation that replaced OxyContin on the market. That was intended to essentially end people's use of opioids. But again, as we know from the first part of this talk, that drug policy is not sufficiently, it cannot on its own just simply end people's use of a particular drug. So what happened, of course, was after OxyContin was removed from the market, we saw increase in the use of other types of drugs, other types of opioids acquired on the unregulated market. Now, unfortunately, shortly after that, the unregulated market radically shifted. So a market that had been primarily focused on heroin and essentially consisted of a global heroin trafficking market suddenly shifted to synthetic fentanyl. And I'll just say that, fentanyl and this increasing potency that we're seeing in the opioid market is a predictable outcome of a supply side focus on trying to end drug-related harms. As you put pressure on any industry for competition, you will create an incentive to increase efficiency. So, we see that in cell phone markets where for a long time, the smaller the cell phone, the smaller the smartphone, the better, right? Like you get the same amount or more computing power into a smaller package, and that is going to win you the market. Well, when drug trafficking organizations are presented with increasing levels of sophistication in terms of interdiction, they will respond. And fentanyl is a very rational and effective response to drug market interdiction efforts, right? Because what you're doing is you're basically putting the same amount of opioid potency into a package that is 50 times smaller. And that is going to be a really effective way to evade interdiction. But of course, what we know is that this has led directly to this massive and ongoing overdose epidemic that honestly has no end in sight and keeps me up at night. So here, in this recent Lancet Commission report that I have a lot of problems with, but also has put together a lot of really nice graphs, you can see they've kind of broken down this, the three waves of this epidemic, the overdose epidemic, right? Where you've got wave one, the rise in prescription opioid overdose deaths, wave two, the shift into the diverted and illegal unregulated markets as a result of access to legal prescribed opioids, and then this massive increase in overdose deaths as that illegal market shifted to in response to increased supply side interdiction to more potent and of course more toxic and deadly opioids in the form of fentanyl. So just a note that this is it is a continent-wide problem, but of course, heterogeneously distributed, overwhelmingly impacting people who are younger. And I'll just contrast that with the COVID epidemic or pandemic, which overwhelmingly has impacted older people. So when you think about the number of life years lost, you actually, the number of life years lost is so much higher on average for people who are victims of the overdose epidemic because they are on balance often so much younger. And that's of course really, really disturbing. And speaking of that intersection, what we found in Toronto and of course elsewhere across the United States and Canada is that the COVID-19 pandemic actually accelerated a lot of the adulteration that we saw in the market. As I mentioned at the outset, I am the lead of a drug checking service in Toronto. If you're not familiar with drug checking, this is a service that allows people to voluntarily and anonymously provide a sample of a drug of unknown composition to have it analyzed and then that information provided back to them. So we run a drug checking service out of 5 supervised consumption sites across Toronto. And we also aggregate findings from this site, from this service to public facing and publicly available monitoring and surveillance platform that's online that you could easily. So I think what's important here is, talking about the heterogeneity across geographies, but also the heterogeneity just in the same setting. So here I've compiled some of our data in Toronto on fentanyl. And here you can just see the average concentration of fentanyl found in fentanyl samples. So you've got these 2 arrows, right? The blue arrow in June 2021 shows that the average amount of fentanyl found was 2.1%, right? So if you've got 100 milligrams, a 100 milligram sample of fentanyl that you think is fentanyl, actually only 2 milligrams of that is fentanyl. But other months, like October 2020, 6.4% on average was the concentration of fentanyl. So that's 3 times the amount of fentanyl, and that is deadly. Like that is going to be deadly for people who are even quite tolerant. And of course, in an unregulated market, you really can't tell what's in your drugs, right? In the absence of something like a drug checking service, which in and of itself can't serve the needs of everybody. Similarly, we've seen this increase in benzodiazepine adulteration, which is not unique to Toronto or Canada. I mean, it's happening all over the United States as well, particularly in the Northeast. Some months you've got about 1% of atizolam, this benzodiazepine-related drug. In other months, you've got 4% on average concentration in fentanyl samples. And so that further complicates the capacity of people to respond to overdoses when they happen, because if somebody is overdosing from benzodiazepines and opioids in combination, naloxone, which is an opioid antagonist, is not going to revive somebody, because the benzodiazepines will continue that depression, that respiratory depression, and keep them at risk of dying. Same thing with cocaine, right? In some months, the average amount of cocaine in a crack cocaine sample was 28%. Sometimes it was close to 90%, right? So people at risk, of course, of stimulant-related overdose mortality as well. I'm just going to move through this a little bit quicker, just because in the interest of time. But the point is that it's far beyond the fentanyl era now. We've got benzodiazepines showing up in fentanyl samples. We have nitazene opioids, which is a whole new class of opioids that have appeared in the unregulated drug markets across North America that are 50, 100 times more powerful than fentanyl. Again, predictable market efficiencies being introduced in response to supply side interdiction. Xylazine, a tranquilizer found now, and synthetic cannabinoids mixed with fentanyl. And, we think of this as a North American problem, but really opioid consumption is increasing, I just note, across many parts of the world. Now, going back to that first epidemic that I described, this HIV epidemic in Canada, there were just a few very simple interventions that were put into place that were able to reduce the HIV epidemic and ultimately get it under control. And the first was pairing HAART with medications for opioid use disorder, specifically methadone. But that dramatically brought down, that stabilized people's substance use, and of course stabilized their HIV infection as well, and prevented AIDS-related illnesses. But there were these other moves that also were really key in kind of ending the epidemic there, related to syringe expansion and distribution being decoupled from retrieval of syringes. A supervised injection facility was open, and heroin prescription trial began as well to meet people for whom first-line opioid medication modalities were ineffective. And you can see that all of that in combination led to a pretty sudden and sustained reduction in HIV acquisition. There's also some really interesting data from Switzerland on this as well. So Switzerland, as some of you may know, in the early 1990s, experienced an HIV epidemic among people who were injecting drugs publicly in parks. And in response, in 1993, the Swiss scaled up supervised injection facilities, heroin-assisted treatment, and needle and syringe distribution. And what's really interesting is that you saw this almost immediate reduction. If you look at the people who were injecting outdoors, almost immediate reduction, and I'll say this was sustained as well in the proportion of people who are injecting outdoors. Also saw an immediate reduction, having a halving of the number of people or the proportion of people who were borrowing used syringes in the past 6 months. But what's also interesting is that their commitment to ending this HIV epidemic among people who inject drugs also had this kind of interesting secondary impact on the number of the incidence of heroin use initiation. So you can see that in all these other countries, including Australia, Italy, England, this was a period in which people were initiating heroin use more frequently. But there was this completely different experience in Switzerland where you had this increase and then this bell curve, right, that you can see, where there was this pretty immediate drop in the number of people who were initiating heroin use. And I've broken this down a little bit, and what you can see here is that right when Switzerland scaled up overdose prevention sites or supervised consumption sites, whatever you want to call them, opioid substitution therapy and needle and syringe programs, there was this massive and sustained reduction in the proportion of people who were injecting in public, but there was also this immediate reduction, within 2 years, basically, of people initiating injection heroin use, right? And that was sustained. And the reason I find this interesting is because this appears to me to be one of the only, if not the only, effective population level intervention that I have ever seen that has succeeded in reducing the number of people who initiated injection drug use. And that's interesting. So that for me spurred quite a long research journey into understanding injection drug use initiation and trying to understand how we can prevent it. And of course, this has implications for both HIV and other disease acquisition among people who inject drugs, but it also has major implications for people at risk of overdose, because we know that injection drug use increases the risk that people will die of an overdose, particularly right now in this period of massive chaos in the unregulated drug markets. So what do we know about injection drug use initiation? Well, we know that almost everybody who initiates drug use or injection drug use was helped by somebody who already knew how to inject, because there's kind of this high barrier or high bar to entry, right? It's very difficult to do it on their own. So then, thinking about this, my thought was, okay, well, rather than trying, we've seen the failures of efforts to try to prevent people from initiating harmful substance use, or risky substance use, I should say, because not all injection drug use is harmful. We know that population level efforts are likely to fail. So why don't we kind of try to get more granular here and start to intervene not on the people who are at risk of starting, but with the people who are in the situation of helping others to initiate injection drug use. The question is, how do we do that? Well, the first step is to understand who these people who are assisting others, and again, remember, almost everybody who initiates injection drug use, cross samples, it's 77% to 100% of people report that they were assisted by others. So people who inject drugs are really central to facilitating the initiation of others. So, this is results from the primer study, Preventing Injection by Modifying Existing Responses, a study that was funded through a NIDA Avenir Award. And really trying to understand again who these people are who are supporting others and facilitating the initiation of others. And we found that contrary to the kind of public discourse around entry into injection drug use, people who assisted others were not really in predatory positions, right? Like most of these, they were more likely to be highly vulnerable to infectious disease. So here you can see that people who reported a higher number of syringe-related infectious disease risk behaviors were 27% more likely, or had a 27% more higher odds of assisting others into initiation. And the other sort of interesting public, well kind of trod idea here was that law enforcement would, and particularly like drug law enforcement of drug markets and drug scenes, would reduce the risk that people would engage in harmful drug use. But by contrast, we found that law enforcement interactions among people who inject drugs actually, in some cases, increased the risk that they would assist others in initiation. And again, so people who were at risk, or people who were experiencing multiple interactions 2 to 5 times in the past 6 months with law enforcement, had a higher odds of assisting others. So not only is drug law enforcement likely or appears to be ineffective in reducing new incident cases of injection drug use initiation, or pardon me, new incident cases of injection drug use, but these interactions may actually be increasing the risk that people who inject drugs assist others, and thereby increase this behavior across vulnerable populations. Now, the primer study looked at data collected from cohorts, Vancouver, San Diego, Tijuana, and also some sites in France. We have some data as well emerging from Toronto and Baltimore from the ALIVE study. And we scoured these cohort studies to understand whether there were any factors that were protective with respect to reducing the risks people who inject drugs would assist others. And very interestingly, we found that people who were enrolled or who had a history of medication-assisted treatment in San Diego had about a 40% reduced odds of reporting that they had ever assisted others into injection drug use initiation. And so that's interesting, right? But of course, lifetime history, that's not something to take to the bank. So we then looked at this in another site in Vancouver, and we found that looking at the past 6 months, a remarkably similar reduced odds, right? And I'm sorry for all the different acronyms, but I'm pulling these screen grabs from papers that used OST, OAT, MOUD. So, I mean, what we're talking about here is medications for opioid use disorder like methadone and buprenorphine. What we found in Canada, or in Vancouver, Canada, was that people who inject drugs who were enrolled in MOUD in the past 6 months had, again, about a 40% reduced odds of reporting that they had assisted in initiation. So then you start thinking, okay, well, that's really interesting. Is it possible that meeting the needs of people, right? And this really requires flipping the script again on this notion of people who inject drugs as predatory, as trying to increase the number of people who initiate injection drug use. Rather than thinking about people like that in those terms, what if we thought about people who inject drugs who are at risk of initiating others in terms of the vulnerabilities that they experience, and what would happen if we met their needs, right? And so, you can see here that meeting the needs of people who inject drugs in terms of their substance use management may actually reduce the risk at a population level that injection drug use behaviors would spread through a social network in a population. And of course, that has secondary preventive implications across the board in terms of HIV epidemics, HCV epidemics, and overdose epidemics. I'm not going to belabor the point too much because I'm always so worried about time, but we found that when we drilled down, it was actually people who were co-injecting opioids and stimulants in the form of crystal meth that saw the greatest reduction in their odds of assisting others when they were enrolled in OAT. And that's really, really interesting, right? So people who assisted others who people who co-injected crystal meth and opioids had an 80% odds, 80% reduced odds of assisting others. So what are the implications here? So number one, I think just going back to the data that I presented from our drug checking service is that drug checking can protect people, right? Having that information about not only what kinds of adulterants are in samples, but also the variation in the concentration can be really, really helpful in helping people in people's capacity to mitigate overdose risk. Overdose prevention sites can also reduce overdose mortality. And here I'll just point out some emerging data that we have from Toronto, where we found that neighborhoods within 500 meters, sorry to use metric, 500 meters of supervised consumption sites saw a 5.4%, saw a rate reduction of 5.4 with respect to overdose mortality in those areas. So sorry, I kind of mangled that, but we saw a 67% reduced rate of overdose mortality happening in areas within 500 meters of supervised consumption sites compared to areas outside of those sites. And I'll just say that the rate reduction that we saw actually extended quite a ways, right? To almost, I mean, in the case here, we saw it as far as 5 kilometers out from these supervised consumption sites, that there was a reduced rate of overdose mortality compared to other areas in the city before and after the supervised consumption sites were implemented. The other interesting, and for this we use coroner's data, right? So these are population level overdose mortality data. These are not cohort data. These are population level data. We also found that the spatial impact of supervised consumption sites on overdose mortality across neighborhoods in which they're implemented actually increases over time. So the local coefficients of SES or supervised consumption site location and overdose mortality incidence actually, like that protective negative association between the location of those two supervised consumption sites and overdose mortality events increased over time. So the longer you have these sites in place, the greater impact they may have on reducing overdose mortality across the population. And this makes sense, right? And I think it's one of the things that people don't quite understand about supervised consumption sites is these are not simply interventions that cater to the needs of clients that enter the sites and engage in medically supervised injecting on site. These are harm reduction hubs that provide naloxone, safer drug use education, referral to treatment, referral to social services. They have all of these knock-on benefits that of course would have impact across a population and across neighborhoods. So, these are unpublished data, but we are working very, very as quickly as we can to get them out for peer review. And then, the other piece here, of course, is that based on the primer data, expanded MOUD access can actually reduce injection initiation, right? So increasing addiction treatment access, making sure that it's patient-oriented, making sure that it's meeting the needs of people who inject drugs can likely prevent incident cases of injection initiation. And here we did some modeling with wonderful colleagues, including Natasha Martin, Anik Borquez, and Sonia Jain, and Steph Stroudy, and many others who were involved in PREPARE, and found that at a population level, you can actually see a pretty significant reduction in the number of people who are initiating injection drug use if you at different levels of MOUD expansion and coverage. And I'll just note, that services, particularly supervised consumption sites and harm reduction services, are most effective when they're tailored to populations, specific key populations. So these are two examples from Vancouver where there is a overdose prevention site that is women only, right? So this obviously is needed because of the particular gendered risks that exist for women who inject drugs. And there's also an amazing organization called Kilala Leilum, which embeds cultural services within a primary care and harm reduction service provider. And so they think of culture as medicine, and some really incredible results have emerged out of their work with people who inject drugs. And just to close out, North America, I would say, is at a crossroad of two futures. Without a regulated drug supply, our future remains unpredictable, but we do have tools to exist, or we do have tools to avert crises and actually get the overdose epidemic under control. And there's really strong and rigorous scientific evidence to support the scale up of these tools. And of course, the other future, which is the future of ongoing failure, like the cost of failure is evident, and we all know what that is. So I will just end there and say thank you so much for listening, and I'll stop sharing my screen. Cannot hear you still, but I think you're talking.
Yeah, I was. Sorry about that. So if anyone has questions, please feel free to speak up or put them in the chat and we'll relay them.
Hey, this is that was great. Dan, I have a quick. I love the supervised centers. That's amazing. I can already see politicians' head explodes about kind of put their heads wrapped around it. But anyway, my question is more about the methamphetamine link with. So do you think it's more just of a more chances because they're injecting more, or do you have other ideas around why that increases?
In terms of like the HIV epidemic in the 1990s?
Increased HIV epidemic.
Yeah, I think, I'm curious what you think. My understanding and sort of the things I focused on is, just the structural interventions that were in place at the time, right? So you had a needle exchange program that had 1-for-1 syringe exchange, right? And so that might be suitable for people who are injecting like 2-3 times a day, like maybe not, but their risk of, or the actual, crude number of injections that they might perform with a non or an unsterile syringe is going to be lower than, of course, people who are suddenly injecting cocaine and stimulants like 20 times a day. So I think it's just a numbers game to a certain extent. I don't know much about the kind of, if anything, I will say, about any kind of influence of stimulant use on HIV acquisition or disease progression. I'm curious whether you have any thoughts about that. That's where
we've been looking at it for sure. My big question at the moment, or at least thought process, is that we're getting better with medically assisted therapy for the opioids, but not so good for the stimulants. Yeah. And I'm just wondering if we're going to have a shift back.
Well, I think what I find kind of interesting about this is that there are data from a number of settings that suggest that, what's evident is that availability drives use, right? And so if we saw this in Australia after the Taliban ban of opium growing, there was this sudden heroin drought in Australia. And what happened was, people stopped using heroin because there was no more around. But there was this shift to stimulant use in the form of cocaine and methamphetamine. And so populations that are reliant on unregulated drug supplies, you see this kind of elasticity in terms of what they use. We've also seen that, what I find really interesting is that there are data from, not only primers showing this potential impact of MOUD on people who use stimulants as well as opioids, but there's other data in other settings that demonstrate that OAT or MOUD can be really effective to meet the needs of people who use drugs other than opioids, right? Like opioids plus other drugs. And so I think, just starting to meet somebody's needs, even if you're not providing substitution, like effective substitution therapies for all of the substances that they use, can be an effective way to stabilize people. But of course, engaging in more work around the development of effective stimulant substitution is going to be key. And I don't know if you're probably familiar with Steve Shoptaw's work, but he's done some clinical trials around looking at stimulant substitution treatments that look pretty promising.
Yeah, exactly. Yeah. That's where I think that's kind of where I was headed about.
And Richard has this really good point here in the chat. Sexual risk of HIV is greater among meth users than opioid users. So people who use meth have injection and sexual risk. Yeah, which is a really important
it's the whole
point.
party and play aspect
Thanks,
around
Richard.
stimulants for sure.
And I just want to shout out Richard because the data that I presented from San Diego is from the STAR cohort that he led. So really rich data there.
You can never shout out Richard too much. So, all right. Does anybody? I don't want to hog everything. Does anybody have any questions? Other questions?
Looks like.
Well,
go ahead, Dan.
No, I was just going to say thanks to everybody.
I was going to thank you. Yeah, thank you so much,
Yeah.
especially for bringing this social epidemiology focus, because, for pandemic response and preparedness, it's extremely important that we think about, all communities, all individuals that are affected. So it's nice to really focus the light on this area. So thank you for that.
Awesome. Yeah, happy to do that.
All right. So briefly, go ahead, Davey.
I just wanted to say this was like an amazing talk, Dan. I've heard you speak a few times, and this was new to me. And I would just want to say congratulations. And I hope that paper that you're working on gets into really big journals and that politicians explode. So sorry, Steele, you go for it.
That would be cool. Thanks,
no problem. So I just want to remind everyone that this is an ongoing seminar series. Next month, we'll have Dr. Flavia Chupezi speaking on November 15th from 2 to 3 p.m. and invites and more information about that talk will be pending. So thank you very much for attending today, and we hope to see you next month.